All right, let's dive into a really fascinating and honestly a very tough clinical puzzle. Complex regional pain syndrome, or CRPS. You might also hear it called Sudeck's atrophy or reflex sympathetic dystrophy. It's a condition that can be a huge challenge, both for diagnosis and for treatment.
So this is the core question we're always asking ourselves with CRPS. You've got a patient in front of you with this awful, debilitating pain, but the event that started it all, well, it might seem incredibly minor. So how do we even begin to connect those dots?
The biggest clue is right here in the official definition. The key word is disproportionate. We are not talking about the normal pain you'd expect after surgery or a fracture. No, this is a pain response that is completely wildly out of sync with the actual injury, and it brings a whole cascade of other sensory, autonomic, and motor problems along with it. Okay, so what actually kicks off this cascade? Let's take a look at some of the most common things that can trigger CRPS. Trauma is by far the most common trigger. Fractures, in particular, are really frequent culprits. Things like a distal radius fracture or breaks in the ankle, tibia, and knee. And what's really interesting is that sometimes it's not just the fracture itself, but the surgery or the cast that follows that seems to set it off. And here we have this critical paradox. It's so important to get this. The severity of the initial injury, it doesn't predict who gets CRPS. You could have a massive, shattered fracture that heals up just fine, while a tiny, non-displaced fracture can somehow launch the full-blown syndrome. This complete disconnect is a real hallmark of the condition. So that brings us to what CRPS actually looks like in a patient. And believe me, it is so much more than just pain. It's really a multi-system disorder that shows up in a few different ways. We can basically break down the symptoms into 4 main categories. First, of course, is the pain itself. It's spontaneous, it's way out of proportion, and patients often describe it as a burning sensation. Second, you have sensory changes, like allodynia, where a simple touch is painful, and hyperalgesia. Third is autonomic dysfunction. This is where you see changes in skin color and temperature, swelling, and weird sweating patterns. And finally, number 4 is motor impairment, which can be anything from weakness and tremors to even dystonia.
Now this really highlights just how complex the pain component is. We're way beyond a simple pain signal from an injury. The idea that pain can be triggered just by seeing something or even by a thought points directly to central sensitization, and that's a key concept for understanding what's going on pathologically.
Okay, so let's track how this syndrome progresses over time. CRPS isn't just one static thing. It typically evolves through 3 distinct stages, and each one has its own clinical signs and even its own look on an X-ray. So in stage 1, the acute phase, everything is hot and inflamed. The limb is warm, red, swollen. On an X-ray, this is when we start to see the first signs of patchy osteoporosis. Then you move to stage 2, the dystrophic phase, and the whole picture flips. The limb gets cold, bluish, or cyanotic as that initial inflammation fades, and radiologically, that osteoporosis gets worse. And finally, you have stage 3, the atrophic stage. This is where we see irreversible tissue damage. Fibrosis starts causing joint contractures, the skin gets thin and shiny, and the X-ray shows this diffuse demineralization, what's sometimes called glass bones. Understanding these stages is absolutely critical because our management has to be tailored to where the patient is in the disease progression. The way you treat stage 1 is completely different from how you approach stage 3. In that acute inflammatory stage, our goal is to just break the cycle. That means hitting it with everything we've got. NSAIDs for the inflammation, anxiolytics for the psychological stress, and alpha-sympatholytics to calm down that sympathetic overdrive. Aggressive physiotherapy is non-negotiable to keep things moving, and we might use calcitonin for its pain-relieving effects and because it might help slow down bone loss. Now, as we move into the dystrophic stage, we're going to continue with that core medication and physiotherapy plan. But as the limb gets colder and more cyanotic, we'll bring in other treatments, like lymphatic drainage, to help manage the swelling and the changing tissue environment. By the time we get to the atrophic stage, the whole focus of our therapy has to shift. At this point, it's really about damage control. The main goal is just to prevent permanent loss of function. This means really intensive, active physiotherapy and using tools like thermoplastic casts to fight against those debilitating joint contractures. So it all comes down to this. The prognosis for a patient with CRPS really hinges on catching it early and intervening aggressively. This question right here gets to the absolute heart of why this matters so much. Recognizing the signs back in stage 1, when we're dealing with reversible inflammation, can literally be the difference between a full recovery and a lifetime of pain with irreversible damage. And that, right there, is our clinical imperative.